All right, let's take another look at our chapter 17 on blood from our Human Anatomy and Physiology text. In part 1, we finished up talking about a hormone which determines the amount of red blood cells in the circulation. Erythropoietin, strange word, EPO, is released from the kidneys when they become hypoxic, and this hormone acts on cells in the red bone marrow, causing them to accelerate the maturation and release of red blood cells into the circulation. So now let's look at the whole life cycle of these red blood cells. Here's a diagram that kind of shows the origin of the red blood cells and the recycling of red blood cells down towards the bottom. So I'm going to break this diagram into two parts to allow us to zoom in a little bit and see what's going on. So at the top we see what we've already just been talking about, the kidneys. If they become hypoxic, release erythropoietin. The erythropoietin goes into the blood and acts in the red bone marrow to accelerate red blood cell synthesis or maturation. 1 billion red blood cells per hour or so coming into the blood. Pretty astonishing function of just a little tiny bit of your body where there's some red bone marrow in all the spongy bone. Anywhere there's spongy bone, your flat bones, the epiphyses of long bones, yes, we have some red bone marrow in there. All right, so the red blood cells come out into the circulation and they remain there doing their thing, carrying oxygen and CO2 for about 4 months. And then they start getting raggedy. They become worn out. Effete is a great word, E-F-E-T-T-E. Effete red blood cells are captured, recognized and captured by macrophages in the spleen and also in the liver, mainly in the spleen. And they phagocytize these red blood cells and recycle them. So if you remember back to our discussion of hemoglobin complex, there's globin chains, 4 globin chains. Well, those are proteins, and they're reduced back down to amino acids in the macrophages, and those amino acids are released back into the blood for use by all your cells in your body to make proteins. The heme complex, is the red pigmented heme, is separated into a oxidized form called bilirubin. It's a yellow-green pigmented color, and the iron atoms. The iron atoms are toxic. They have to be avidly hung onto by carrier proteins so that they don't get into trouble reacting with things. And those iron atoms are carried by ferritin or hemosiderin to the liver where they're stored. The heme ring, as I said, is converted to bilirubin, and the bilirubin goes into the blood, but it's very avidly scavenged up by the liver. So there's normally no bilirubin to speak of in the blood. The liver then places that bilirubin in the bile, a product that it creates and secretes into the intestine, which helps with digestion of fats, but it's also the route by which this bilirubin is excreted from the body. It enters into the intestine and is converted to stercobilin by bacteria in the intestine, and that's what gives feces its brown color. If it weren't for the recycling of the red blood cells, the feces would be white, amazingly. So what nutrients do we need in order to make all these red blood cells? Globin chains. We need iron to place iron atoms in those heme discs. Vitamin B12 and folic acid are important nutrients that are required for production of red blood cells, and so those need to be absorbed in the liver in order to have the nutrients necessary to do this incredible production job. So here we have written on this slide a little bit more. Amino acids, lipids, and carbohydrates we need to make red blood cells. Iron, so you need to have sufficient iron in your diet. You need vitamin B12 and folic acid. Vitamin B12 is interesting because we can't absorb vitamin B12 from our intestine. It's produced by bacteria in our intestines, or maybe in our supplements, in our food. And in order to absorb it, we need a substance called intrinsic factor, a peptide from the stomach, secreted by the stomach, which then allows vitamin B12 to be absorbed in the intestine. Problem is, intrinsic factor secretion declines with age. So geriatric medicine involves a remediation of the problem of not having enough vitamin B12 absorbed into the blood, so that many elderly people don't have enough red blood cells, and we'll be talking about that next. Anemia. Anemia, let's get this definition. Now remember, when you're studying, don't just zip out to Google to get definitions. If I give you a definition, you can bet that I want you to know that definition. There's lots of alternatives, and I don't like them. All right, so anemia is an abnormally low oxygen carrying capacity of the blood. Don't say not enough red blood cells. That isn't a specific enough or a more accurate enough description. So it's a low oxygen carrying capacity of the blood. You're not getting enough oxygen from the lungs to the organs that need it. We'll look at a bunch of kinds of anemia, but let's talk first about sickle cell anemia. Sickle cell anemia results from a genetic mutation in which one single amino acid in one of the globin chains is substituted. It's mutated. It's changed. So let's take a look at that. All we're going to do is take this one glutamic acid and replace it with a valine. And when we do that, it changes the whole property of the globin chains such that when the hemoglobin is in the deoxy state, so if this person is exercising vigorously or stressing out, then the hemoglobin polymerizes and the red blood cells get rigid and arc-shaped like this. And obviously that's not a good thing. The blood cells have to be supple and elastic, and they need to stretch their way into blood capillaries. And when they become sickle shaped like this and stiff, they can't get into the blood capillaries. They jam up. There's what's called crashing. The red blood cells start to lyse and burst out and release all their hemoglobin, which is nasty stuff. It does terrible harm to the kidneys and so forth. This is a horrible situation. It's called a crisis. The person is probably going to be in excruciating pain and have to go to the hospital. So sickle cell anemia is a bad disease that prevents people from getting into situations like exercising in a healthy way, which causes sickling. Why do we have sickle cell anemia? Why is it so prevalent in members of a certain ethnic groups in the population, African American people? Well, I'll tell you why. Because the theory is that because people with sickle cell anemia are more likely to survive a malaria infection, we have a positive selection pressure which keeps sickle cell anemia mutation prevalent in the population, even though it's a very deleterious mutation, which you might think otherwise would begin to select against itself. People would not be as successful in survival. So we have a lot of people with sickle cell anemia, relatively speaking, in the world. One way to prevent sickle cell anemia is by treating with hydroxyurea. It induces the production of fetal hemoglobin. There's a different type of hemoglobin, different globin chains, and fetal hemoglobin doesn't sickle. So if you can induce the red bone marrow to produce more fetal hemoglobin, you'll be in better shape. There's other things that are used for treatments to try to sort of reduce the incidence of crashes or crises in sickle cell anemia. There's some experimental treatments involving stem cell transplants and gene therapy. Hopefully someday those things will help us eradicate this disease. Other types of anemia, kind of break them up into categories. Types of anemia that involve insufficient red blood cells. The worst of those is called aplastic anemia. When you're talking about cell biology, plasticity refers to mitosis, multiplication, making more cells. A is a prefix that means not. So aplastic anemia means the red bone marrow is not making red blood cells. And usually when that happens, none of the cells are being made in the bone marrow. It's being destroyed or compromised in some way by either a drug treatment that can have a terrible side effect in certain people. Some bacterial infections, the bacteria secrete toxins that destroy the red bone marrow. Some people's immune system attacks their own red bone marrow and stops the production of blood cells. These are fatal disorders if they go to the extreme. Radiation treatment. If you have radiation treatment for certain types of cancers, you may destroy the red bone marrow. So that's a terrible thing. Sometimes it arises spontaneously, and sometimes it resolves spontaneously and never comes back. Hemolytic anemia. Lysis means breaking of cells, bursting of cells. Hemo, blood cells. Hemolytic anemia is a condition in which there's too many red blood cells being destroyed faster than they can be produced, so you don't have enough red blood cells and enough hemoglobin, not enough oxygen carrying capacity. If you had a transfusion mismatch, that'll cause massive lysis of red blood cells, put the wrong blood type into a recipient. Certain parasites, we don't think of parasites really when we're thinking about all the diseases we might encounter in our lives. In some parts of the world, parasite infections are highly prevalent. And so certain parasites eat red blood cells, and you might have an anemia resulting from parasite infection. Sepsis just means a terrible, terrible infection in your body, such that it's going to start influencing the blood itself. And people with sepsis may have anemia, among the other horrendous things wrong with their body. Hemorrhagic anemia. Bleeding. Hemorrhage means to bleed. You can have either an acute hemorrhage, losing a lot of blood in a short time if you have a traumatic injury, a car crash, or who knows what all, or have a major surgery in which you've lost a lot of blood, then you'll have anemia for a time until your red bone marrow can catch up and replace those red blood cells. You may, of course, also have some transfusions, some blood cells introduced into your body from outside. Chronic bleeding. Some people have severe hemorrhoidal bleeding, right? We don't think of that too much either. Hemorrhoids are considered kind of a discomfort in the rectum or in the anus. Some people have these hemorrhoidal veins. We'll talk about those at some point, that are inflamed veins in your anus. In some parts of the world where they don't have great health care and great ways of controlling these kind of things, they may wind up with a chronic bleed from advanced hemorrhoids, and that can lead to anemia. What about the esophagus and the GI tract? As people age, there are a number of conditions that can lead to bleeding in the GI tract and anemias. But here's an especially bad case. This is a picture, a scope picture of an endoscope picture of the esophagus, of someone's esophagus. It's been kind of puffed up with air so you can see in there and shine a bright light and get a video camera in there. And the surface looks all ripply. It's not how it's supposed to look. All the veins of this esophagus are bulging into the lumen terribly. They're all over-distended. And what happens when you have a chronic case in which the veins are all over-distended, because there's too much pressure in there, and you keep eating food and swallowing, and it chafes as it travels down this pipe, the esophagus, eventually it'll cut through the wall of the epithelium there of the esophagus, and bleeding will happen, and you'll have these chronic bleeds down into your stomach. You'll probably, if this happens frequently, you'll probably die of poisoning due to excess amino acid metabolism in your intestine. It involves deamination, removing the amine group from all the amino acids, which produces a large amount of ammonia, which can kill you. People with severe liver disease, people with alcohol abuse, a history of alcohol abuse that are in the late stages of cirrhosis of the liver, wind up with this backed up pressure in all the veins of their GI tract, and it can be particularly bad in the esophagus because of the friction. So, it's an interesting thing. These bulging veins are called esophageal varices. All right, renal anemia. What if the kidneys are diseased and they can't produce erythropoietin normally? That causes a type of anemia, right? Because we don't have the signal to influence the bone marrow to make enough red blood cells. What if you don't have enough hemoglobin production, which is exactly why I don't want you to define anemia as not enough red blood cells. You could have plenty of red blood cells, they may be deficient in hemoglobin, still not enough iron or oxygen carrying capacity. If you don't have enough iron in your diet, then you may have good hemoglobin being produced, but yet insufficient amounts of it, and anemia. Pernicious anemia is what it's called when you don't have enough vitamin B12, as we said earlier. You don't have enough vitamin B12 because you don't have intrinsic factor from your stomach, for example, or you don't have access to enough vitamin B12 in your diet, or the bacteria in your intestine aren't producing enough. But typically, pernicious anemia comes from insufficient absorption of vitamin B12 in elderly people, and they can't divide the red blood cells can't divide during the stage of their life cycle. You wind up with these great big red blood cells that are not normal in function. They're called macrocytes. Anyway, pernicious anemia is a very serious condition potentially. What if you have abnormal hemoglobin leading to an insufficient amount of hemoglobin? Two genetic anomalies of hemoglobin production. One is sickle cell anemia. We already learned about that. And that can lead to sickling and cell lysis and anemia. Thalassemia is another disease in which there's a mutation in the globin chains of hemoglobin, and there's a missing globin chain altogether. And so we have these very fragile red blood cells that have this very strange hemoglobin complex in it. This is prevalent instead of in people of African American descent, in people of Greek descent, thalassemia. All right, so that's our discussion of anemias. I'm trying to pause in here for a moment. So we want to talk about something that's the opposite. What if you have an overabundance of red blood cells? It's called polycythemia. Polycythemia. Too many red blood cells or excess red blood cells. You could have cancer of the red bone marrow in which there's an overproduction of red blood cells. That's called polycythemia vera. So that's a pretty serious condition indeed. But more often, much more often, there would be secondary polycythemia, some kind of a signal that's causing excess red blood cell production. What if you went up to a location at very high altitude, above 10,000 feet elevation, and just kind of camped out there and stayed there? Well, the adaptation of your body, one of the adaptations will be to produce extra red blood cells, right? Your kidneys will sense hypoxia. They'll produce extra erythropoietin. They'll produce extra red blood cells, and voila, you have polycythemia. And you'll just live like that. It's one of the ways your body can adapt to living at high altitude and be comfortable there. And finally, blood doping. Sometimes people inject themselves with erythropoietin in order to improve their athletic performance in aerobic sports. If you know you need a lot of oxygen carrying capacity to ride your bicycle up the side of the Pyrenees Mountains in a race, you may inject yourself with erythropoietin, produce a lot of extra red blood cells, and now you have an advantage over all your rivals, although they're probably all doing it, which is what kind of happened in the Tour de France. And you may have heard some years ago when Lance Armstrong was kind of, I don't know what the right word is, convicted of blood doping and stripped of all his 4 or 5 first place wins in the Tour de France because he was cheating so touch. The sad thing is, the guy's a freak of nature, and he probably was capable of winning at least one just on his own. But he got tempted by inappropriate behavior and did that. So our next section is a quick look at the white blood cells. These are called leukocytes. 5 kinds of white blood cells that are called leukocytes, as just a catch-all term. And the leukocytes represent about 1% of the blood volume. We said that erythrocytes, red blood cells, represent about 45 to 48% of the blood volume. Leukocytes about 1%. If we look within there, we see the relative abundance of different kinds of leukocytes here in this bar graph. So neutrophils are the most numerous of the white blood cells. So N for neutrophils in this silly little mnemonic device to remember the order of the relative abundance. Next most populous white blood cells are called lymphocytes, for let. Lymphocytes are, we'll take a look at all these different cell types in a second. They're immune cells. Monkeys, monocytes is the next most populous category or type of white blood cell. And then finally, eosinophils are next, and finally basophils are extraordinarily rare. Hardly any basophils in their blood at all. So let's take a look at, here's a little snapshot of actually micrographs of each one of these types of white blood cells. We've been right stained, just like you did in lab, and is how it kind of should have come out looking. Let's go and look at each one of these types of white blood cells. Oh, incidentally, leukocytosis is the name of a condition in which your white blood cell count rises in response to an infection in your body. If you have an infection or inflammation in your body, the number of white blood cells will drastically increase, particularly neutrophils. That's called leukocytosis. So if you see a blood smear of your patient and they have 5 times more white blood cells than they should, you'd know they probably have an infection. So anyway, neutrophils. Neutrophils are the most populous, and they have this multi-lobed nucleus. It looks like a balloon animal or something like that. That's how you can recognize them. And the way they function, they circulate and just take a ride in your blood most of the time. If you get an infection in your body, an injury with infection, then these neutrophils will, at sites of inflammation, crawl out of the circulation and travel to the site of infection and inflammation and phagocytose and kill microorganisms, bacteria that are infecting your body. Lymphocytes, the next most populous type of white blood cells, they are cells of the immune system, which again, in your circulation, are just taking a ride. Some of them live in various different places in your body, lymphoid tissue, or what we call reticular loose connective tissue. When we talk about tissues, it's also called lymphoid tissue. So a lot of neutrophils live, I keep saying that. lymphocytes live there. Anyways, they're tiny little cells, almost as small as a red blood cell, and the whole cell is just about taken up by nucleus because they're not doing anything. If you activate one of these in response to an infection, then they expand and grow and turn into a more mature cell that has a specific role, such as producing antibodies. Monocytes, they're the largest of all of these cells, and like lymphocytes, monocytes have no granules in their circulation. I'll mention that again in a little bit, but lymphocytes have no granules. Look at the granules in this neutrophil, or look at the granules in this eosinophil. Anyway, monocytes are agranulocytes. They're the largest of the white blood cells. They have this characteristic U-shaped nucleus, and these cells are on their way somewhere. They come from the red bone marrow, circulate for a while, and then they leave the circulation and mature into macrophages. Right? That's where all the macrophages in your connective tissue proper comes from. Obviously, the areolar connective tissue has macrophages which surveil the tissue for infections and foreign material and debris, and phagocytize it, gobble it up, and destroy it. Eosinophils are rare white blood cells that have a role in defense against parasites in your blood. Some parasites have larval worms that have a part of their life cycle in their blood, and these cells will attach onto there and secrete nasty substances to help kill those parasites. Also, people with a lot of allergies will probably have quite a lot of eosinophils in their blood. I have a nice micrograph of Dr. Davis's blood with lots of eosinophils in there, and I'll try to remember to give that a look in class, or maybe I'll send it to your lab instructors. Here's a nice right stain that was done in our lab class, our A&P lab class. You can see the reason I wanted to show you this one is this beautiful eosinophil, a fairly rare type of red blood cell. You may not have seen any of them in your lab class today or yesterday. I guess it will be by the time you see this. So here's an eosinophil that did appear in someone's nice right stain of their blood. So you can see a lymphocyte down here and a neutrophil and an eosinophil. Finally, we come to basophils. Basophils are vanishingly rare. There's very little chance you'd ever see a basophil if you did a bunch of blood smears. Anyway, these cells have a role in activating inflammation when there's tissue damage or infection. And they're granulocytes. You can see this purple color, but they have all these little granules in their cytoplasm. Where do all these come from? They come from the red bone marrow, right along with red blood cells. So there's stem cells in the bone marrow that, in this case, give rise to progenitor cells that will commit to the life cycle of making white blood cells. We classify all the different types of white blood cells and their sort of developmental cycles as either lymphocytic, over on the right side here, or myelocytic. All of these cells are called myelocytes versus lymphocytes. We'll mention that again later when we talk about leukemias. And here we see the three types of granulocytes: neutrophils, basophils, and eosinophils. They all come from differentiation of progenitor cells that originate as stem cells, myeloid stem cells, that then give rise to myelocytes. And then over here we have the agranulocytes, the non-granular white blood cells, monocytes, or I'm sorry, not monocytes. Those are actually part of the myelocytic scheme, and the lymphocytes are the lymphocytic types. So this is just a summary slide. You don't need to memorize the numbers of the various white blood cells per microliter of blood. If you're somebody who's like working in the hematology clinical lab, you'll know these things by heart, and it won't be a thing. Real quick, the last thing we should mention though is platelets. Platelets are not cells at all. They're fragments of cells released from huge multinucleus cells in your red bone marrow called megakaryocytes. And megakaryocytes just keep breaking off chunks of their cell membrane and cytoplasm filled with chemical-filled granules that circulate in your blood, and they're important for blood clotting. So blood clotting is called hemostasis, right? Trying to stop the blood from escaping from the vascular system. It's a subtype of homeostasis. You want to keep the blood in the circulation so it can do all of its important jobs. And in this case, it's called hemostasis specifically. All right. So what are we going to need if we're going to stop bleeding? We need two things. We need a bunch of proteins that come from the liver called clotting factors. We mean clotting proteins. There's a whole family of proteins, as we'll see in a minute, that have to be produced. Every single one, missing one single clotting factor means bleeding disorder. And we need platelets. You've got to have platelets to have good coagulation or clotting. There's three steps to blood coagulation. We're going to look at vascular spasm, platelet plug formation, and coagulation, the actual clotting. I should move this slide. Here's a megakaryocyte produced by differentiation from stem cell division in the red bone marrow, giving rise to blood platelets. All right, so what do we got? We have a damage to a blood vessel. We have a torn blood vessel, and blood is leaking out. We're bleeding. Well, the first thing that happens is some platelets adhere to the surface where the blood vessel wall is torn, and they release their granules. When they release their granules, one of the components of the granules is a chemical called serotonin, and serotonin causes the smooth muscle in blood vessels to contract. We're going to constrict those vessels down so to help block a lot of the blood flow from coming to this damaged area. That's called vascular spasm, major contraction happening there. Also, when the platelets become activated, they get sticky. New receptors are placed on their surface, which allows them to attach to all kinds of proteins on the surface of these, on red blood cells, on the surface of everything around here, the wall of the blood vessel particularly. So the platelets begin to stick, and they form what's called a platelet plug, and it's a positive feedback system. As platelets stick, they start releasing these chemicals, and the chemicals are going to help activate more platelets. Thromboxanes are short-lived lipid mediators that cause new platelets to come floating by to be activated, get sticky, release their granules, and they join in and stick to this growing plug of platelets on the tear in the blood vessel. And this keeps happening and happening until we plug up that opening by just a mass of sticky activated platelets. Platelet factor 3, which is also part of the platelet granule composition, activates coagulation. It starts to make the blood clot too, besides making the cells sticky. So now let's take a look at the coagulation step. That's the process by which some plasma proteins are going to turn from liquid form, from dissolved proteins, into an actual gel, a fibrous gel. And here is a schematic diagram of coagulation. It's insane, right? Let's break it in half at least and just quickly look at the top half of this and then the bottom half. The intrinsic pathway is what we've been talking about. We activate platelets when there's a torn blood vessel wall. Some collagen fibers are sticking out. Platelets stick to the collagen fibers. They get activated. They release their granules. Thromboxanes come. Plug happens, etc. Well, the platelet factor 3 is going to join in here. As we'll see, we're going to activate a series of enzymes in your blood that are clotting factors. All these Roman numerals represent different proteins that are produced in your liver. They circulate in an inactive form, and then when the platelets get activated, it's going to start activating these enzymes. So this enzyme gets clipped, a little peptide gets clipped off, and it's now active factor 12. Factor 12 is an active enzyme which clips off a little piece of factor 11 and activates that. This is the A for activated. Well, factor 11 plus calcium and also factor 7, activated factor 7 will activate factor 9. You don't have to memorize this entire scheme, but I'm showing you what's going on. Factor 9, along with factor 8, will activate factor 8, and this factor 9 and factor 8 complex will together activate factor 10, if you can believe it. Activated factor 10, along with calcium and platelet factor, again, activates prothrombin activator. Now we're getting close to something dramatic happening. Prothrombin, once activated, is going to become active thrombin. Prothrombin is a circulating plasma protein that has no activity, but once it's activated by prothrombin activator, it's thrombin. Thrombin is the final step in the coagulation cascade or process. Thrombin will turn fibrinogen, the soluble plasma protein, into fibrin, an insoluble fibrous protein. It just collects into giant masses of sticky protein webs. That's what we call fibrin, is what we call the blood clot. It gets toughened up. There's another function of factor 13 here, which is to cross-link. It's like these proteins are so sticky they form a gel. Well, now we're gonna permanently connect them together into the sticky mass of fibers. It's going to hang everything together and really help prevent from anything from breaking out of the blood vessel. No more bleeding. But a lot of this is happening outside the blood vessels. When the blood leaks out during bleeding, blood coagulation happens. And this fibrous scaffolding is the beginning already. It's going to become the beginning of a new temporary type of repair tissue called granulation tissue that's going to allow some cells to crawl out on these fibers and start building new collagen fibers and making new tissue to repair the injury. Whew, that's a lot of stuff, isn't it? Well, we'll come back and finish up this chapter when we take a look at part 3. So join me next time as we wrap up our discussion of chapter 17.